Hi, this is Dr. Beals, and this is the Week 10 information on Chapter 42 and Chapter 45. Now, you'll stop your readings in Chapter 42 on page 999, and I've indicated that in the ebook. We will pick that back up later in the program, next semester actually, on IV medications and administration. So let's go ahead and take a look at our objectives. So these are our objectives for this week, and you will notice I've highlighted several areas on the objectives because those are going to be the main points that we will cover during this week. The other objectives are objectives that you probably have already discussed in other courses, and as you know, the courses in the curriculum are very integrated, so you'll need to be bringing that information forward with you to this class and throughout the program. So let's begin the discussion talking about acid-base balance. Maintaining pH within a normal range is very important for optimal cell function. As you see in this picture, the acid-base system comprises of three primary elements, including the buffer system, the respiratory system, and the renal system. Now, if the pH goes outside of the normal range, enzymes within cells don't function properly. Hemoglobin also is not managed, does not manage oxygen properly. And the result of all of this is serious physiological problems that can occur, including death. Laboratory tests of a sample of arterial blood is called arterial blood gas, or ABGs, and they're used to monitor a patient's acid-base balance. Homeostasis is the key to understanding the concepts related to acid-base balance. Now, the body normally maintains a steady balance between acids continually produced during normal metabolism and the bases that neutralize and promote the excretion of the acids. Because these acids alter the internal environment of the body, their regulation is necessary to maintain homeostasis and thus acid-base balance. Many health problems can lead to acid-base imbalances. For example, patients with diabetes, chronic obstructive pulmonary disease or COPD, and kidney disease frequently develop acid-base imbalances. The acidity or alkalinity of a solution depends on its hydrogen ion concentration, or H+. An increase in hydrogen concentration leads to acidity, and a decrease leads to alkalinity. Hydrogen concentration is usually expressed as pH rather than in milliequivalents. The hydrogen ion concentration is inversely proportionate to the pH. For example, the lower the pH, the higher the hydrogen ion concentration. Now, the pH of a chemical solution may range from 1 to 14. A solution with a pH of 7 is considered neutral. An acid solution has a pH less than 7, and an alkaline solution has a pH greater than 7. But when we're thinking about the body, and particularly blood, blood is slightly alkaline, and the normal range is between 7.35 to 7.45. Yet, if it drops below 7.35, the person is considered to have acidosis, even though the blood may never become truly acidic. If the blood pH that is greater than 7.45, then the person has alkalosis. The buffer system is the primary regulator of acid-base balance, and buffers act chemically to either lower or raise the pH. All body fluids, including blood, contain buffers, with the main ones being carbonic acid and bicarbonate. For example, when the extracellular fluid becomes acidotic, a cellular shift causing hydrogen ions to enter the cell with potassium exiting. Therefore, increases or decreases in blood plasma potassium occur in acidotic alkalotic states. So, what do we know about potassium? Well, we have to remember the terms hyper being elevated and hypo being decreased. This buffer system acts immediately and is the fastest response to alterations in this acid-base imbalance that's going on in the body. Now, the next component is the respiratory system. And the respiratory system mechanism is the next fastest. So it usually occurs within minutes to hours when an acid-base imbalance occurs in the body. So in the respiratory center of the brain, the rate of excretion of CO2 is controlled. For example, when CO2 or hydrogen are too high, respirations are increased to get rid of that excess CO2. We call this hyperventilation. The opposite occurs if these are too low. So hypoventilation occurs, thus causing a lowering of the hydrogen. Now, problems in the system arise when there is either respiratory problems or there are problems with the brain's control mechanism in the medulla, which controls the respiratory center. Oxygenation is measured using arterial blood gas sampling, and the PaO2 measures the partial pressure of oxygen in arterial blood and is the most important factor in determining how oxygen binds to hemoglobin. If the PaO2 is high, then more oxygen is able to bind with hemoglobin. But if the PaO2 is low, then less oxygen is able to bind with hemoglobin. Now let's talk a minute about carbon dioxide, or CO2. This is a natural occurring byproduct of cellular metabolism, so it's happening all the time in our body cells. Carbon dioxide is measured by the PaCO2 levels, which indicate the partial pressure of CO2 in the arterial blood. The PaCO2 is used to evaluate the respiratory component of acid-base balance. So when I speak to CO2, that's really what I'm meaning, is the PaCO2. But for simplicity purpose, we'll just stick to CO2. So we know now that this is primarily regulated by the ventilatory function of the lungs and that center of control in the brain. So when normal arterial CO2 levels are 35 to 45, PaCO2 greater than 45 is related to hypoventilation or excessive CO2 retention. A PaCO2 or CO2 less than 35 is related to hyperventilation or excessive exhalation of CO2 and therefore alkalosis. It is important to remember that an acid-base imbalance is not a disease, but a manifestation of an underlying health problem. We always want to consider the possibility of acid-base imbalance in patients with serious illness. Next up is the renal system, which is the slowest to respond to the acid-base imbalance. The role of the renal system is to reabsorb and conserve all of the HCO3 or bicarbonate. Also to secrete or save it for later the free hydrogen from the renal tubules, which combine the hydrogen with ammonia or excrete, get rid of, weak acids. That is why healthy urine is slightly acidic with a pH of 6. The compensatory mechanism of the kidney is to reabsorb additional bicarb if the pH is too high, or eliminate excess hydrogen if the pH is too low. Now, a key point to remember is this is a slow process. It usually doesn't begin for at least 24 hours and will take sometimes days to work to correct an acid-base balance. And that's an important point, especially with the manifestation of underlying health problems, because we know that acid-base imbalance is not a disease, but there's something else going on that's causing the acid-base balance. So the compensatory mechanism of this buffer system, the respiratory and renal, can only work so long. And in any illness or condition of the system, it can impair the mechanisms complicating the goal of achieving balance. So let's recap. Because normal metabolic processes produce acids, the body must neutralize and excrete them to maintain a normal balance between acids and bases. The body has 3 mechanisms by which it regulates the acid-base balance to maintain the arterial pH between 7.35 and 7.45. These mechanisms are the buffer system, respiratory system, and renal. Do you remember which one takes the longest? The regulatory mechanisms react at different speeds. The buffers react immediately. The respiratory system responds in minutes and reaches maximum effectiveness in hours. And if there is a respiratory problem, that is the cause of an acid-base imbalance, for example, respiratory failure is a good example, the respiratory system loses its ability to correct the pH alteration. Now think about that older adult that has impaired compensatory ability because of decreased respiratory function. That can definitely impact the mechanisms involved with this particular system in trying to maintain that balance. So, key point, with increasing CO2 levels, that these stimulate those chemoreceptors in the brain associated with the respiratory drive. And thus, we see an increase in respiration rate and effort as the body makes the attempt to excrete the excess CO2. We see a decrease in CO2 levels, which creates an increase in pH because of a decrease in hydrogen ions. So we have hypoventilation versus hyperventilation. So under normal conditions, the body depends on the kidneys to reabsorb and conserve all of the bicarbonate they filter and excrete a portion of the acid produced by cellular metabolism. So remember, with the kidneys, there are 3 mechanisms of acid elimination, which are the secretion of small amounts of free hydrogen, the combination of hydrogen with ammonia to form ammonium, and the excretion of weak acids. To compensate for acidosis, the kidneys can generate additional bicarbonate and eliminate excess hydrogen. This increases the blood pH and decreases the urine pH. If the renal system is the cause of the acid-base imbalance, such as in renal failure, it loses its ability to correct the pH alteration. So they both describe acts of separating things. So the main difference between two words that are key here, which actually derive from Latin words, think about the prefix "ex" meaning out, while the prefix "c" means setting aside. So you can remember that excretion is something that is sent out because it has no further use, while a secretion is something that is set aside because it might have future use. So the goal is to restore balance. The kidneys regulate the bicarb level in the extracellular fluid. And during respiratory acidosis and most metabolic acidosis, the kidneys excrete hydrogen ions and conserve the bicarbonate ions. In respiratory and metabolic alkalosis, the kidneys retain hydrogen and excrete bicarb. So remember, all renal compensation is very slow, hours to days. So would this work with metabolic acidosis caused by renal failure? Now that's where it gets a little tricky. We're not going to talk a whole lot about compensation at this point in time. Our focus is primarily to be able to interpret just some basic respiratory, metabolic, acidosis, and alkalotic conditions. So arterial blood gas can be collected from the radial, brachial, or femoral artery. Generally, a respiratory therapist or trained nurse can obtain ABGs from the radial and brachial artery. The collection from the femoral artery is usually performed by a physician or an advanced practice nurse. And in the critical care setting, patients may have an arterial line, which is present for invasive blood pressure monitoring. ABGs can also be obtained from this line repeatedly without injury to the patient, so they just draw the arterial blood from that line. ART lines are considered safe with a complication rate of less than 1%, and usually the radial artery is cannulated, but the second most common site is the femoral artery. Now, before we obtain ABGs from the radial artery, you'll notice an Allen test being performed. And the reason why we do this Allen test is to check collateral circulation of the wrist and hand. The purpose of the Allen test is to occlude both the radial and ulnar artery, exsanguinate or remove the blood from the hand by clenching the fist, and then release the ulnar pressure to determine a return to blood flow. If the hand does not retain color or blood flow, another site should be selected. Now, knowing the normal values of ABGs is a must, and when we discuss ABG interpretation, we will mainly be looking at the values of pH, PaCO2, or CO2 for short, and HCO3, which is the bicarb, or CO3, to determine whether or not it's respiratory or metabolic acidosis or alkalosis. We won't be talking anything about compensating, so that we'll save that for another day. ABG values provide an objective information about the patient's acid-base status, the underlying cause of an imbalance, the body's ability to regulate pH, and it also tells us the patient's overall oxygen status. So we have to have knowledge of the patient's clinical situation and the physiologic extent of renal and respiratory compensation, which will allow you to identify acid-base disorders, as well as the patient's ability to compensate. ABG readings are also important in determining the oxygen status of the patient. So, for example, the SaO2 tells us the oxygen saturation of the blood, and the PaO2, or the partial pressure of oxygen, tells us the oxygen carrying capacity of the blood. Both are very different in terms of how and what we use the values in management of the patient. So ABGs are not solely used for acid-base balance, but um, the attainment of ABGs has other uses as well. Now we're going to be learning the tic-tac-toe method of analyzing ABGs specific to acid-base imbalances. So if you have a chance to review Nurse Sarah's TikTok video, that would be great. If not, we'll take a peek at it in class. So here we have the normal values for pH, PaCO2, HCO3, and then there is also the base excess, the PaO2, and SaO2. So the PaO2 indicates it does not measure the amount of oxygen available to bind to hemoglobin. It does measure the oxygen carrying capacity of the blood. It is not the measurement achieved by pulse oximetry, but it is the measure achieved using arterial blood gas. So here's a bonus. How is this SaO2 measured numerically? So you have a hint, number. Is it millimeters of mercury, milliliter, liter, or something else? I'll let you think on that a minute, and we'll discuss it in class. Okay, so the tic-tac-toe method is one of the most simplistic methods of interpretation of ABGs, and it's basically done by sorting out the differences in values in a grid fashion, whether respiratory or metabolic, and the pH. So at the top of the grid, you can see the tic-tac-toe. I have distinguished the acid, which would be greater than 45 for CO2 and less than 22 for HCO3, what a normal pH CO2 and HCO3 would be, and the basic, with the CO2 less than 35 and the HCO3 greater than 26. So these column helps us to place the values where they fall and whether the patient is acidotic or alkalotic. The position of the CO2 and HCO3 reveals the origin of the acid-base balance, whether it be respiratory or metabolic. And if the pH and CO2 fall in the same column, then the problem is respiratory. But if the pH and the CO3 fall in the same column, the problem is metabolic. So one of your most important roles as a nurse is that of a detective. So we're always trying to figure out these problems and solving the mysteries that occur with our patients. So how do we do this? Well, remember the clinical judgment model. We notice or we gather that data during the assessment of the patient. We want to be gathering a subjective data, health history, medication history, surgical and other treatment history. Then we assess each body system, gathering the objective data, which is the measurable based upon standard deviations of normal. And all this information gives us clue to helping solve the mystery of the patient's problem and intervene with nursing interventions or calling the provider to alleviate the suffering and expediting those treatments ordered by the provider. And then we respond and we reflect on all these things. So let's break down each of the four respiratory acidosis, alkalosis, metabolic acidosis, and metabolic alkalosis. So when you're talking about pathology for respiratory acidosis, this is the primary acid-base imbalance resulting from altered ventilation leading to CO2 retention. So as that acid increases in the blood from the carbonic acid, which is the chemical part of the rising of the CO2, this can cause certain signs and symptoms with your assessment. And there are also many reasons why this acid-base imbalance occur. Remember, acid-base imbalance is not the condition. It's it's what's happening as a result of a cause or condition. So you have to think to yourself, well, what would cause alterations in ventilation? Well, there are a lot of different things, such as CNS depression. Remember, the center of respiratory is in the brain. So taking barbiturates or sedatives can cause that CNS depression. Maybe respiratory muscle fatigue or impairment. Think about a chest injury. Maybe a respiratory condition that would cause atelectasis, which is the collapsing of the alveoli in the lung. And that can be caused by pneumothorax or maybe a pulmonary infection. Also, bronchial obstructions such as an asthma can cause respiratory acidosis, heart failure with pulmonary edema, and if you have weakened respiratory muscles. Now, there are a number of neuromuscular diseases that can cause this, but I primarily indicated age here. So as we age, we have weakened respiratory muscles, which can affect respiratory acid-base imbalance. So some common signs and symptoms you'll see with this would be dyspnea, restlessness, headache, tachycardia as the heart tries to compensate for the low oxygenation in the body. And then, of course, if we don't get good oxygen to the brain, good blood flow with that oxygen, we can get confused, um, eventually lethargic, and then you can see alterations in the heart rate in terms of regular or irregular rhythms, and we call that dysrhythmia. Respiratory alkalosis, on the other hand, is usually caused by hyperventilation. So I'm breathing hard, breathing hard, breathing hard, breathing all of that CO2 out of my body, which thus lowers my CO2 and increases my bicarbonate or HCO3. And that can lead to increased oxygen consumption. Sometimes hyperpyrexia or really high fevers and CO2 production. People that are experiencing fright or fear or pain, anxiety, fever, even pregnancy will cause respiratory alkalosis because of hyperventilatory syndromes. And then salicylate intoxication and overdose is a very common cause of respiratory alkalosis. So what signs and symptoms might we see with this? Well, we'll see increased respirations. Of course, this might be the cause if they're hyperventilating. And then we'll see decreased concentration, confusion. They'll get this characteristic paresthesia or tingling and numbness in the fingers and toes. We once again see cardiac dysrhythmias, and they may even feel them by feeling palpitations in their chest. And they'll become real sweaty and at the same time get a dry mouth as that parasympathetic side of the nervous system starts to work in overdrive, and blurred vision. Now, there are specific manifestations or signs and symptoms with salicylate overdose, and salicylates are a certain medication. So we'll not go into that in great detail right now, but keep that in the back of your mind for the future. Metabolic acidosis is usually the pathophysiology behind that is we have this decrease in serum bicarbonate caused by increase in hydrogen. We have a loss of the alkali or the bicarbonate due to maybe severe diarrhea or maybe malabsorption in the GI tract itself, or the kidneys might be involved, such as with decreased acid excretion by the kidneys. There are many causes. Once again, notice that the kidney and the GI system are involved very much. But also, you have these hypermetabolic states, such as people that have really bad burns or high degree burns and sepsis. These are hypermetabolic states that will affect acid base balance. Signs and symptoms include headache, confusion, restlessness, lethargy, a particular kind of respiration, which I'll show you in class, that's related to diabetic ketoacidosis, which is a type of metabolic acidosis. They will be nausea and vomiting, dysrhythmias, warm flushed skin. That's another kind of characteristic of metabolic acidosis. So, just a note about metabolic acidosis related to hyperglycemia or high glucose levels in the blood. You want to be sure you are carefully monitoring the patient's potassium because there's this shift of potassium back into the cells and out of the plasma when we provide the key treatment for diabetic ketoacidosis, which is rapid acting insulin. So just think in your mind's eye when you have been studying about electrolytes what this shift could do in the body. So we've got more than one problem here, but you'll be able to talk about diabetes and diabetic ketoacidosis in depth very soon. And last but not least is metabolic alkalosis, and it's generally caused because there's an increased loss of acid through the GI tract, and then sometimes the kidneys are involved. Some causes are excessive uses of bicarbs or antacids, but also vomiting, nasogastric suctioning, so suctioning a lot of contents out of the stomach and upper GI tract, diuretics, just having hypokalemia or hypercholemia, which is high chloride, increased aldosterone, renal loss of hydrogen due to diuretics or steroid use can cause metabolic alkalosis. And some common signs and symptoms include muscle involvement, such as weakness, dizziness, lethargy, convulsions, and eventually you can have depressed respirations, disorientation, coma, and death. Okay, I wanted to say one thing about metabolic acidosis and metabolic alkalosis, and this is actually an Easter egg in your notes in your ebook, but a good way to remember or not to get these two confused in terms of vomiting and diarrhea is to think about this. So if it's coming out of your butt, it's going to be a base. So base comes out of the butt and acid comes out of the stomach. Okay, let's recap. So we've gathered this data, and a lot of times in these conditions, there are many times are emergency conditions. So you have to do a quick focused assessment, and then you all are learning about assessments in your lab and clinical, I'm sure. But keep in the back of your mind the weight gain or loss in terms of fluid balance. If a patient has more than 2.2 pounds or 1 kilogram in 24 hours, that's cause for concern. Blood pressure is very much linked to fluid imbalances. Pulse rate quality and characteristics, EKG changes related to all three, so electrolyte, fluid, and acid base, as is respiratory rate and oxygen parameters. We listen to heart and lung sounds. Take, for example, a patient that maybe has fluid imbalance related to heart failure. We look at the extremities, inspect them, palpate them for, edema or increases in edema, or maybe that feeling of the numbness or tingling in the extremities. We look for mental status changes, like changes in level of consciousness, um, their behavioral changes. We look for neurological changes such as seizures, or perhaps with certain electrolyte imbalances, you will see increased or very marked deep tendon reflexes. And then abdominal. So, we auscultate that abdominal. We palpate it if they're distended, if they're got hyperactive or hypoactive bowel sounds, or maybe they have cramping of their abdominal area. That would be an indication of some forms of electrolyte imbalances and even acid base. Okay, so what interventions do we do? Well, fluid and electrolyte replacement. We can do this either orally or by parenteral therapy means, and I'll give you that definition here in just a minute. We may have to restrict fluids if, for example, they have a condition that they're have water intoxication, where they're drinking too much water, or they have some kind of sodium imbalance. Remember, sodium is the largest amount of electrolyte in your body is sodium. Sometimes we have to get aggressive and do measures to correct acute issues. With many of our acid base imbalances, they're usually acute, or maybe they have excessive fluid or electrolyte loss or gain. So, even though we're not going to talk about intravenous therapy in this class, you still need to know the term. So, anytime we're talking about perennial therapy, we're talking about therapies or fluids or solutions that are given through intravenous routes, whether it be peripheral or a central intravenous route. When we're talking about enteral therapy, we're talking about their fluids or solutions or feedings we're giving through the gastrointestinal tract. So that's the main difference between those two, and that's a term that's going to be very important to you in remembering. Okay, let's go on to chapter 45 and talk about nutrition. I know that you will be pulling forward much of this information, so I've tried to just focus on, what the highlights are in terms of, bringing those connections from your pre-nursing courses to what's relevant in nursing. And as a nurse, you're very much in tune to nutrition because, as we know, poor nutrition is kind of the crux of all, or not all, but most health issues that people experience. And without this basic component of health, we can see problems in terms of organ function, our cellular metabolism, tissue maintenance, repair, even your immune system, and normal growth and development, such as infants, toddlers, young children. Now, in this country, many years ago, the National Institute of Health developed this program after noticing concerning outcomes that were occurring called Healthy People. And it started with Healthy People 2020, but now we have Healthy People 2030 objectives. And these are data driven national objectives to try to improve the general health of the population in the United States. Now, there are leading health indicators which are high priority and to address over this next decade. And among those, priority indicators includes the reduction of household food insecurity and hunger. Now, you would think that it would not, that would not be a problem in this country, but it actually very much is. The most recent data that we have is from 2018, and the target that they have set for household food insecurity and hunger is 6%. Well, in 2018, about 11.1% of households in this country were food insecure. So, what do I mean by that? Well, this is what I mean. They did not have access to healthy food resources. And there are various reasons why that is, and it is, related to income, of course, and it's also related to environment. For example, in many urban areas, there are what they call food deserts. So you may have access to food, but it is not healthy food. So, like fresh fruits and vegetables. So, maybe they have a convenience store in the neighborhood that's readily available, but you know as well as I do what you can just about only get at convenience stores is potato chips and Reese's peanut butter cups. So that can be a very difficult problem to solve in all areas of the country. I think about our rural populations. You would be surprised to know that there is food insecurity quite prevalent even in this area of southwest Missouri because of the rural population and distance to access healthy food. So that is definitely an issue that we have. So we have a set scientific knowledge base that we know we have to have appropriate carbohydrates, proteins, fats, water, of course, vitamins, and minerals to allow our body to function the way it should. Now, your textbook breaks down each of these, but I thought I would point out the differences between fat soluble vitamins and water soluble vitamins. So, fat soluble vitamins, they're stored in the fatty compartments of the body, and people acquire the vitamins through dietary intake. Although vitamin D actually comes from the sun. The body has a high storage capacity for these fat soluble vitamins, and we have to be cognizant of this because toxicity is possible when people take large doses of them. And also, um, since this fat soluble vitamin, one of them is vitamin K, that can interfere with some medications and the blood clotting of the body. So, fat soluble vitamins include A, D, E, and K, and water soluble includes C and the B complex, which there are 8 different B vitamins in that group. So, we call hypervitaminosis of fat soluble vitamins the result of these megadoses, whether it be intentional or unintentional. Supplements of vitamins, but you can also get hypervitaminosis through excessive amounts of fortified food. So we eat a lot of fortified food in this country. And in some areas, if you have access to, you know, fatty fish, you can have large intakes of fish oils. So I just thought I would bring that up in regards to a nursing perspective. Now, you all have had physiology, and you probably are pretty familiar of how the body ingests nutrition and breaks it down, absorbs it, and eliminates it. So let's just quickly go through each of these steps. So digestion, we're mechanically breaking down that food. We start in the mouth using the teeth, the gums, and then we swallow it. And absorption includes the body absorbing that nutrient, and that can be done from 4 different ways, either from passive diffusion, osmosis, such as with water and sodium, and active transport and penocytosis. And then we have the metabolism and storage of the nutrients. So we need good nutrition to make sure that our body functions the way it should, and that we're healthy in all of those biochemical reactions that occur every second within the cells of our body. And then we have elimination. So as the chyme moves down by peristaltic action through the large intestine, it is all of the water is absorbed in, or most of the water is absorbed, and the remaining product is excreted as feces. Now, in this country, there we have food guidelines, which helps with, the nutritional aspect in terms of teaching. And that's brought out as my plate. So we know we need a set amount of protein, carbohydrate, fats in the diet to make sure that we're having good regulation of our body processes and staying healthy. You would be surprised at how many disease processes are actually caused because of poor nutrition. Take, for example, cardiovascular disease, which has been highly linked to um, poor diet, high cholesterol diet, high fat diet, and of course, lack of exercise, contributes to that. So, we all need to be mindful of what we're eating, and to help our body function well, and also to feel good. So that's important. All right, there are factors that influence nutrition, such as environmental factors, developmental needs throughout the lifespan. For example, infants through school age, they have developing bodies and brains. Very much the brain is developing um, probably at the most rapid rate between infancy and being 5 years old. So we have to approach nutrition very carefully with this. So encouraging breastfeeding. And if you can't breastfeed, getting a high quality formula, and being cautious when you're introducing solid foods. We also have to approach cautiously foods with a high incidence of allergic reaction, with infants through early school age children, such as wheat, eggs, nuts, peanuts, even citric juice and chocolate, are high risk or a high incidence of allergic reactions in children. And then we have to be very cognizant that we have this steady increase in the rate of childhood obesity. So as that toddler approaches school age, um, you know as well as I do that their access, which this is part of the food insecurity of healthy meals in school, can be somewhat limited. In adolescence, adolescents are also developing both body and brain, and they're very susceptible to poor dietary habits. And about 25% of their daily nutritional intake is through snacking. And this is the time frame of aging that we see the onset of eating disorders such as anorexia nervosa and bulimia nervosa. Now, both are linked to body image perception disorders, but anorexia nervosa is probably more linked to that. And anorexia is differentiated from bulimia because there is this intense fear of gaining weight. Many times, or some, a lot of times, a person can actually have both. So bulimia, we link, a good way to remember this is bulimic patients will tend to binge eat followed by purging episodes because they have this inappropriate compensatory behavior that, they can moderate their behavior in that regard. Now, young to middle adults, usually pregnancy and lactation are a factor that influence nutrition. And when you reach age 65 and older, we also have factors such as the decreasing need for energy as our metabolism slows as we age. We do need the same vitamin and mineral requirements throughout middle adulthood, and with the aging with the older adult, age-related changes such as a decrease in appetite, taste, smell, and maybe digestive problems such as constipation can influence nutritional intake. There are multiple factors that can contribute to the risk of food insecurity in the older adult. Income is one because most older adults live on a fixed income, so they have, limited funds to buy healthy food. And then they may have lack of transportation or the ability to get to the grocery store. Also, there's a social aspect to meals. So, if they've lost their spouse, they don't have that social interaction at mealtime, which makes mealtime enjoyable for them. And with the high population rate of older adults, nurses, we have to be aware of the unique nutritional needs and issues faced by the older adult. Um, there are drug and food interactions that can be factored in for both adults and older adults. For example, most steroids will increase the appetite and cause weight gain, and they also cause us to lose calcium if they're used for, over the long term. Drugs such as antibiotics can often interfere with absorption of certain vitamins, such as vitamin K, which is essential for blood clotting mechanisms. Many cultures and religions prohibit the use of meat in their diet and certain meat products, such as abstaining from pork or pork products. Some inhibit the use of alcohol, and there's ritual fasting in a lot of cultures and religious beliefs. Even though cultural considerations with nutrition are not necessarily more or less nutritious, diets for these various religions and cultures must be considered to support the patient or the population. For example, if a patient is following a vegetarian diet, which is practiced by many people, and there are different variations of vegetarian diet, so we have to ensure that they're getting adequate protein needs and having adequate vitamin and mineral intake. So, as we begin to assess our patients and thinking about the nursing process, gathering all that good data specific to nutrition, we use a lot of nutritional assessment tools. These are great evidence based tools that have been tested for reliability and validity and generally are easy to use. And when you're assessing a patient that you suspect there might be a nutritional problem. So you see here the mini nutritional assessment, or MNA. That's one of many tools that can be used in the clinical environment. And it's just a series of questions or maybe measurements that we use, and we score them. And if their score is within a certain range, then there is um, within that range, they can be considered malnourished or at risk or even normal. We use another type of test called an anthropotomy, and that's a systematic method of measuring the size and the makeup of the body. Of course, we get electrolyte and other biochemical tests. We get their diet history and health history. We do a physical examination, and we have to be cognizant of swallowing issues, otherwise known as dysphagia. With acute care, there are certainly risk factors for them in terms of nutrition. Take, for example, if they have problems with swallowing, we have to be very careful in terms of ensuring that the patient is not aspirating or swallowing food and it going down into the respiratory tract. We have to advance their diets carefully. We have to monitor their diets carefully, such as with the patient with diabetes. And, the hospital and hospital food, and sometimes changes in diet, say, for example, an adolescent that is maybe newly diabetic and has to go to a diabetic diet, that can be very difficult. So we have to help, promote their appetite by offering, good food choices, but letting them have some control of what they're choosing. Sometimes we have to help feed um, or assist with the oral feedings patients using special devices in tools. Say they have had a stroke and maybe they need an adaptive device that, as you see here in this picture, to help them be able to feed themselves. Now, when we cannot provide oral nutrition, sometimes there are conditions or complications that require what we call an enteral tube feeding. So remember, we already defined perennial and enteral. So we're providing those nutrients through the GI tract, through maybe a tube, either in the nose or mouth, or sometimes even in the inserted surgically into the abdominal area, into the jejunostomy or the stomach itself, to help provide temporary or sometimes even long-term nutritional support. Now, there are 4 types of enteral formula: polymeric, modular, elemental, and specialty. And these are very much modified for the patient by the nutritional specialist according to, their specific physiologic needs. Take, for example, a patient that maybe has a burn, which is a hypermetabolic state, and we are supplementing their nutrition with enteral tube feeding. Well, they may need a certain percentage of protein versus carbohydrate, and certain percentage of vitamins that the nutritional specialist will help the provider in, kind of designing that and ordering that. Now, there are certain complications with enteral tube feedings, and we'll talk about that here in a second when we talk about safety. As a reminder, perennial nutrition is that nutrition that we administer intravenously, whether it be a peripheral intravenous device or a central intravenous device. Our main concerns with perennial nutrition is preventing complications, just like with enteral. Um, feedings, and we most generally use perennial nutrition with high-risk metabolic needs, such as certain GI surgeries, trauma, traumatic brain injury, and like I've said, burn patients. So these are patients that cannot digest or absorb any nutrition within their GI tract, or they are in such a high metabolic need that they need this additional intravenous nutrition. So, some things to think about safety wise as you learn the skill of inserting a nasogastric tube and enteral feeding tube and start that process is you always want to verify the appropriate connector is attached to the enteral tube when administering the tube feeding. You want to use aseptic technique when you're preparing and delivering the feedings. You want to ensure that you're labeling the equipment with the patient's name, room number, formula, the date and time of initiation, your initials, the rate. I have at one time in my career seen a terrible never event where a nurse or on a patient that actually had a central line with IV fluids infusing and a enteral feeding, and a nurse unfamiliar with the equipment and the fact that both tubes were not labeled properly, got them confused and actually connected the enteral feeding to the central line. So these are important safety guidelines to follow to help protect our patients. So we treat this just like you do the rights of medication. So I have the right patient, the right formula, the right tube, right adapter, right equipment. So that is a standard of practice for medications, for anything just about. We want to make sure we're checking for delayed gastric emptying. We take residual volumes, and they'll explain how to do this in lab. And because having high residual volumes in the gastric um, content can cause problems with or high risk for aspiration. So you want to be sure you're checking those residual volumes as per the physician's orders, or if there's not a specific order volume wise to check, a good rule of thumb is if the volume is 250 to 500 milliliters when you check that residual volume in the stomach after 2 consecutive assessments 1 hour apart, then we need to be stopping that feeding and contacting the provider to let him know that we've got a delayed gastric emptying problem. We always want to place our tubes, confirming that placement with an x-ray verification before we start putting any feeding down it or even water to that effect. We used to auscultate over the stomach and listen for kind of a gurgling sound when you inject air into the tubing, but that is no longer best practice. We want to do an x-ray confirmation. Now, at the bedside, you'll see nurses check the pH of secretions to confirm that tube location, but this is done on an ongoing basis after that initial placement is verified. So, with a patient that is getting enteral feeding, we want to make sure we position their head upright or elevate that head of the bed at minimum 30 degrees, but preferably 45 if they can tolerate that. We want to trace all lines and tubings back to the patient to ensure only enteral to enteral connections are occurring. We don't want to add any food coloring or dye to the enteral nutrition feeding. We used to do that a long time ago as well. And the thought process behind that was if we added a little bit of green food coloring, then we could be able to quickly determine is this the feeding that they're coughing up or just phlegm, because you'll notice that the secretions that come from the lung look very similar to enteral feeding, or they're that same color. We want to make sure we're following manufacturing guidelines on our equipment, on our feeding, when we're determining how long the feeding should hang. So, for example, a lot of times the feedings will come in bags. Sometimes they will come in pre-prepared packaging with expiration dates on them. So we want to be following those guidelines. And we always want to use an enteral feeding infusion pump when we're administering continuous enteral feedings, or feedings that are, going at a certain milliliters per hour continually as opposed to intermittently. We also want to use infusion pumps for perennial feedings. So that's very important as well. But we have to be mindful of the type of pump. So, don't get a enteral feeding pump confused with an IV pump. So I'd like to tell you one never event that occurred on a patient. Um, you know, Feeding tubes and central lines and perennial therapy, all of these more advancing techniques, as you're going to be learning more and more about, have very high risk to them. So that's why we have to cross our T's and dot our I's and make sure we're following proper procedure. So in this picture here, you see a picture of a guy's skull, and he had actually he had brain surgery, and he had a tumor resected transnasally through an endoscope, which so they went up the nose and broke the sphenoid bone and took that tumor out endoscopically. Well, he had a feeding tube placed during the surgery under x-ray confirmation, and unfortunately that feeding tube fell out a few days later and was replaced at the bedside by an on-call physician without visual control of that tip. In other words, they didn't have an x-ray right there as he was putting the tube feeding in. Well, the tip of the tube obviously did not go where it should have, and it actually went up through where that surgical area was, back down through the bottom of his skull and on down into his spinal cord. So when they discovered this, the guy had left-sided weakness, and the tip of the tube was actually below his diaphragm when they did an abdominal x-ray and a CAT scan, is how they discovered exactly where it was at. Unfortunately, the physician who tried to replace the feeding tube failed to see that the tip of the tube as it went in, and he was unaware that this had happened, and the patient ended up to be permanently quadriplegic and actually died about 7 months later. So they did what they call a root cause analysis, because this is a never event. And trust me, a bunch of policies were enacted and procedures were analyzed. And what they came down to was, communication is very key in understanding established, policies. And so this type of thing would never happen again, hopefully, with somebody. Now, aspiration pneumonia is another high risk for enteral feedings, and especially nasal gastric feedings, because, sometimes you can have high gastric content because delayed gastric emptying, and maybe that tube's migrated up too far up out of the stomach into the esophagus. And we have to be alert for that and the signs and symptoms of, respiratory distress. Okay, so that's all for week 10, and we will have some fun in class this week doing some activities. So pay close attention to the tickets to class and the little notes and Easter eggs I've left for you in the ebook, and I'll see you then. All right. Have a good evening.